Hello, everybody. I'm Anamika. I'm one of the intensive care consultants at Harvey Bay Hospital, and today we'll be learning about transcutaneous pacing. What we'll go through in this video would be a brief summary about what transcutaneous pacing is, what are the indications. We'll go through a video explaining the steps, and then a take-home message. So, what is transcutaneous pacing? It actually is a temporary means of pacing a patient's heart externally by delivering an electric current through the patient's chest wall and stimulating the heart to contract. So, the important bit here is that we are doing this externally compared to an internal pacing, which would be either temporary or permanent. Internal pacing, the electrode is placed directly into the right ventricle through a transvenous route, and the electrode stimulates the right ventricular myocardium and hence stimulates the heart to contract at the desired set rate. So, as is self-explanatory, is that this is temporary and this is an external procedure and this is a bridge procedure. So this is a procedure which we use to get some control over the situation, get the heart rate up, get some perfusion into the patient while we're preparing to put in an internal pacemaker, whether it's in an intensive care unit or a cath lab. So coming to the indications, the most common indication is symptomatic bradycardia, unresponsive to drug therapy. By symptomatic bradycardia, we mean a heart rate of less than 40 beats per minute, which is associated with some symptoms of cardiogenic shock, which clinically manifest as a low blood pressure, usually less than 90 systolic, altered mentation, cool peripheries, organ dysfunction, low urine output, and so on. And we have tried drug therapies like atropine, glycopyrrolate, isoprenoline infusions, and adrenaline infusion, and we do not see any effect. These are usually high-grade blocks which are not amenable to drug therapy, and hence we have to get on to transcutaneous pacing ASAP. Asystolic cardiac arrest, not in all of them, but carefully selected ones wherein we know that there is an underlying conduction defect. These would be patients who've had a big MI and you're suspecting that that's destroyed the conduction pathways. Failed intrinsic pacemaker. And the most important bit is to seek alternative causes of bradycardia, the 5 H's and 5 T's, like hypoxia, electrolyte imbalances, hypothermia, etc. So we need to treat them before we embark on transcutaneous pacing. Let's now go through this video which explains us the steps involved in transcutaneous pacing. Of doing transcutaneous pacing. Before we start the actual procedure, we'll make sure that the patient's got oxygen connected and has basic monitoring like a non-invasive blood pressure, SATS probe, and we have an IV line which is running. So let's come back to the actual machine. So this is the LifePack 12. Your department might have a different one, but the basics are the same. Here we'll concentrate on the panel that's here. One bit actually has a defibrillator bit, and the other one, which we are more interested in, is the pacer, which has the starting button for the pacer, the rate, the current, and then there's a pause button as well. And then there's this little wheel which can be used to dial up and down the parameters. Just down below the wheel is the attachment to the pads. So the defibrillator pads are attached through that to the machine. On the other hand of the panel, the one that's connected is the lead's going to ECG. So that's where we connect the ECG dots onto. Very important to remember here is that just the pads will not work. We do need the ECG leads to be on in order to pace the patient. It is a very common mistake especially in a cardiac arrest scenario where we have the defib pads and we're trying to pace and we can't because we don't have the ECG on. Just about that, we have the other monitoring bits as well, like the non-invasive blood pressure, saturation probe, as well as a little attachment for end-tidal carbon dioxide, especially in cardiac arrest scenarios. Alright, so we'll go through, before we start to attach the leads and the pacing pads, we need to talk to the patient if they are awake about what we are going to do, because this is a painful procedure. And if they are awake and have a decent blood pressure, it's reasonable to give them some analgesia and sedation. But if the patient's shocked and almost peri-arrest, we can skip that. Okay, so let's start with attaching the ECG box. As you would normally. And next would be the pads. Now the pads go apical and basal, and if there is any confusion where they go, the pads actually have a little diagram of where they go, so just follow that. That's just below the right clavicle, and that's where the apical one goes. It's on usually 5th or 6th intercostal space, anterior axillary line. There you go. Okay, so now we connect the bars. So there's usually this attachment which needs to come out, and then we connect it to the pads. Okay, now we're going to start the machine by pressing the on button. Once we press the on button, we'll get
connect electrodes.
it's connected, isn't it? Alright, so now look, it's on the AED mode. We need to change it to a pacer mode, so we press the pacer button. So here we've got, so we can see that the intrinsic rhythm is at 24 beats per minute, and now we set the rate. So the rate can be set up either by going up and down the button or by turning the wheel. So the wheel turns up by 10 and the button turns up by 5, so it's up to you what you want to use. So we go up to a desired rate. Ideally you would go around 80 to 90. You might have to go up if the cardiac output still is low. So for this example, let's put it up to 80 beats per minute and then press confirm by just pressing the wheel. Then it automatically goes to the next setting, that's the current. And so depending upon the clinical situation, if the patient is very unstable, peri-arrest, you would go up, like try to go up to the maximum current and then come down. But if the patient's awake, then you start slow and go up because it is painful. So we start with around 30 milliamperes and then see if we are getting capture. So electrical capture actually means that you have a QRS complex followed by the pacing spike. So the vertical line is the pacing spike, and then we get the QRS complex. So here we're seeing that all the pacing spikes are not followed by a QRS complex. That means we're not getting capture. So we will have to go up on the current. So we go up slowly by 5 to 10 till the point we get electrical capture. So here we see that each pacing spike is followed by a QRS complex. So that means we have capture, but we'll go 10 milliamperes above the threshold just to be safe that we don't lose capture if there's change in sensitivities. Right, so this is our electrical capture. We have to make sure that we have mechanical capture as well, and that would be whether we have a pulse and have a good blood pressure, which we didn't have, as well as we have a better SATS waveform on the monitor. Thank you.